Hi, welcome to another video from the CTAG Clinic. I'm Dr. Mike Lloyd, I'm the director of the clinic. Today we're going to be answering a question that one of the subscribers has left with us, which is wanting to know a great deal more about depersonalization and derealization disorders, also known as DPDR. So this is part of the dissociative spectrum of disorders, and I'll talk a little bit about exactly what those are and try and answer the questions as best as I can do as we go along. The first question that was asked was, am I going crazy? And that is a classic question for people that find themselves in a pattern of dissociation. And the answer, of course, is absolutely not. The whole purpose of dissociation is to defend somebody from some form of harm. So we would think of that as a traumatic experience. So depersonalization and derealization can occur almost at any point in a person's life. These do not have to be things which have their origins in childhood, but I would say it's likely that if a person is having traumatic experience early in life that lead to these sort of conditions taking place, then they're likely to be more vulnerable to them later on if they encounter further traumatic episodes later on in life. But for the time being, these are ways of defending themselves against a traumatic experience. It could be a one-off, or it could be something that happens over a period of time. If it's a one-off, it's likely to occur and then sort of leave after the event. It's unlikely to be something that is maintained over time. If it's something that takes place over a long period of time, i.e. this goes on and on and on for a period of months and years, it may well be that the DPDR symptoms are much more likely to sort of form part of the fabric of that person's experience going through the rest of their life. I'll start with depersonalization. Depersonalization is around the person's connection to their own body. So the type of symptoms, the things that are being experienced by that person are largely around their relationship with their own body. So what we look to do is try and understand whether or not it's considered to be enough of an experience that would label it as a disorder. And in so doing, what we have to do is rule out other things. So we have to rule out things like medical illness, we have to rule out whether or not sort of alcohol, substances, things like that are taking place. It has to be something to cause significant distress and impairment in their life. It has to be something that goes on for a long period of time. So some of the key signs or symptoms that we look for in depersonalization is the sense that a person is outside of their own body, that they may experience numbness or a sense of not feeling like they belong, that the body might be alien, it might be too old, it might be too young. It just feels wrong in a way. Ultimately, there's a lack of connection and the person feels a distinct, separate quality to their relationship with themselves and with their body. One of the other features is that there may be a lack of connection between the person and their own emotional experience. So it may feel that they don't believe that their emotions are within control, or a sense that the emotions might be coming in from somewhere else that don't belong to them, or they have no control or regulation over their own emotional systems. In derealization, the same features essentially apply in terms of the exclusion criteria, but it's more about the person's experience of their environment. So it's the things around the person that may seem unreal or foreign or alien to them. So examples might be of derealization, that a person doesn't recognize a room that they're in that should be familiar. They may not recognize people around them that should be familiar. It could be that the tonal quality of their environment has changed or has shifted somehow during a dissociative episode of derealization. Colours may seem too bright or too muted. Colours might be monochromatic rather than vivid in tone. Sounds could be muted or overly loud. Generally speaking, the person's filtration system with their environment can be all over the place. So a person might be fine in one moment and then suddenly feel as if the room is changing size, or that the colours have changed, or the people have changed, or the nature of their environment has changed somehow. And they feel that there is an emotional response to that. So it's not experienced in a neutral kind of not caring way, but it's experienced in a way that leads to distress, and both the depersonalization and derealization can actually impinge upon that person's ability to function. The experiences that they may have within either DP or DR can cause them significant distress. It can cause problems in relationships. It may have gone on for an awful long time, and it actually imbalances their ability to be able to just cope and function in everyday life. One of the questions that was asked is what causes these disorders to happen. I suppose, again, as we talked about in traumatic experience, it can be that there's such an overwhelming impact of an experience that it leads a person to not want to be in their body. So something that might be happening to the body can be so scary, can be so frightening that the person actually doesn't really want to have anything to do with it. So an example might be if you have a terrible accident and there might be sort of a limb amputation, or it could be that there's an enormous physical insult to that body part, and you're looking at it and you just cannot connect to it. There's natural anesthetic that is kicked in from the system, from the adrenaline response, and you don't feel as if that part of the body is actually yours. It looks so odd, so alien, and so strange. So from an immediate traumatic episode, it could be that you just don't want to be in that body in that moment in time because something so severe has happened. For other types of things, let's say abuse, one of the most common descriptions of depersonalization that occurs is when a person feels as if they're floating above their body while it's being harmed. So let's say in childhood, if the body is actually being harmed in an abusive way, the person's consciousness sort of removes itself from the body as an act of separation to protect itself, so that it appears to the person as if it is not happening to them, it's happening to the body as if it was somehow a different object. And therefore it makes a reduced connection to that abuse, reduced connection to that behaviour, so the person doesn't actually experience that terror and distress from the experience that they would have done had they not separated. In derealization, it can be very much the same. So the environment is so threatening and so terrifying for that person, is so highly stressful, that to remove themselves, to change the nature of that environment, can actually act as in a protective way. So some of the people that might be in the environment might appear to shift and change, and the colours and the tones and the sounds, everything can appear slightly alien. One example of derealization is a person who believes that they are in a video game rather than in the real world. What that does is it allows them to believe that the real world is not quite real, and that has a protective quality if the reality of their experience is so awful that it almost becomes too much to take on. So an example of how I deal with this in the therapeutic setting is I might say to a person that's had some really terrible experiences throughout their life, and they have this derealization response where they feel as if there's some like an automaton walking through life, and they're not really connected to the world, they're not connected to themselves. And I say, well, okay, I'll give you a choice. Would you prefer to be completely connected to your abuse history, to know that it was real, to have every aspect of that made real for you and to feel real and to know that it was true? Or would you prefer to feel as if you were an avatar in a video game, walking through life without a sense of reality, not believing that the things around you are actually true, and having a sort of a disconnected reality to everything that goes on? And inevitably people choose the second option, because to actually confront the reality of a traumatic experience for some people is so overwhelming they cannot bear to do it, so they shift themselves away. When we come back to that question of why I'm crazy, you can see how this might be picked up within, say, psychiatric settings or assessments with a psychiatrist or with a clinical psychologist in mental health settings, when they're asking a person to describe the nature of their reality, and that the answers they're getting back are things like I'm dead, or I don't feel alive, everyone around me is an alien. I've been kidnapped, I've been taken away from my own reality, and I've been sort of like replaced by aliens, or that everyone around me are somehow not really the people that I think they are. They're pretending to be my family, but I know they're not. And I'm seeing things and I'm hearing things and I'm experiencing the world in ways that everyone tells me is simply not the case. So we might then start thinking about that person having delusions or psychotic episodes, hallucinations, auditory and visual, and what that means is they end up likely on antipsychotics, rather than thinking that there is depersonalization or derealization occurring within that person. Which leads us on to one of the other questions, which is why is it that so many professionals don't seem to understand what DPDR is actually all about? And the simple answer to that is I don't think anyone's really trained to do that. In terms of the actual training courses that psychologists, psychiatrists and therapists go on, the basic level of training doesn't really have much on dissociation, and certainly doesn't focus on things like DPDR. There may be some focus on dissociative identity disorder, or DID, because that's more well known. And actually within the construct of DID, people are likely to experience both depersonalization and derealization symptoms, but maybe not have those as being the most prominent aspect of the difficulties that they're experiencing. So a person with DID might present much more with different alters, different identities within their system, and the fact that they don't really connect to their body or connect to their environment might be overlooked. So sometimes we can miss out on the more subtle but very important aspects of DPDR in favour of a larger diagnosis, which is a little bit more obvious. But the people that have DP and DR really find it incredibly difficult to cope with. So it can cause dissociative symptoms like an absence of self. So the person really doesn't ever feel that they belong in their own body, and they may hate the body and they may attack the body in order to even see whether they're feeling anything. So deliberate self-harm can be a real feature of depersonalization, because the person doesn't feel connected to their body and they're attacking it because they don't like it, because they should be connected to it and they're not, or that it carries trauma memory in terms of abuse that may have been enacted upon it, and therefore the person doesn't want to have anything to do with it. So professionals may again look at the deliberate self-harm and think, okay, emotionally unstable personality disorder, but not necessarily think this is someone with an abuse history who carries depersonalization, who is struggling to cope with being in their own body. And again, with their environment, it's much more likely with derealization for a person to end up with a psychotic type diagnosis rather than a diagnosis of derealization. One of the other things about both of these conditions, which is true generally for dissociation as a whole, is that there isn't a medication which can make it better. Medication can be used to sort out some of the sort of like the secondary effects of any sort of traumatic condition. So anxiety, sense of tenseness and nervousness, or low mood, or inability to regulate mood. So some medications can actually help with those symptoms, but they don't actually get to the root cause of the dissociation. So no medication really sorts out trauma, but what it can do is it can help a person be more stable and feel as if they've at least got themselves together enough to be able to explore what the trauma might be about. So for some people that feel incredibly destabilized about addressing the nature of their trauma, were they to take some sort of antidepressants or anti-anxiety medication, it might just give them enough of a platform with which to start exploring the work, or to be able to even reduce their anxiety enough to enter into the therapy room in order to make the difference to be in their understanding. The main treatment options for depersonalization and derealization are psychological therapy. So whether with a psychiatrist, a psychologist, or a therapist of some form, it's about being able to understand the nature of the traumatic experience and the impact with which it's happened. It's detective work in a way. A person has a set of symptoms about their depersonalization, so they're disconnected to their body, or they're seeing their body in different shapes or sizes, where it feels alien, it doesn't belong to them, it hurts in ways that they can't understand, or it doesn't hurt in ways that it should if it's in pain. And to be able to lead that person to try and understand exactly what the nature of their experience is that led to those symptoms. We come back to that essence of dissociation, that it's about logic, that there is a reason behind why our symptoms exist in our body and in our relationship to our environment, and these are connected to the traumas that we have sustained. So it's very unlikely for a person to have depersonalization, for example, or derealization without a traumatic experience in a way that triggers the disorder categories to be formed. A person can experience derealization, for example, if they're simply in a very strange situation, if they're in a very alien environment to them, or they're in a highly stressful situation. It can occur and the person can feel separated from their environment very quickly, but that doesn't last very long, and it wouldn't trigger the category of a disorder. It would simply be a derealization experience, because the brain holds the ability to dissociate, so therefore it's able to bring about dissociation in small ways that don't become disorders. They don't have that impact on our everyday functioning. And I know certainly for myself, I've been in environments where, let's say in a job interview or something that I've done that is particularly stressful, and I can remember standing apart from myself, almost having like a metacognition. I can think about my own thought processes and remember saying to myself, look at me doing this. Am I really doing this? So if I'm in a completely unique and strange environment that I never thought I would be in, that may have come as a bit of surprise, I have actually depersonalized in that environment and thought, I don't really feel like I belong here. Is this me doing this, or is this somebody else doing this? But it didn't last very long. It maybe lasted 10, 15, 20 minutes. That's simply an experience that the body has generated to help protect me from an immediately stressful environment that didn't then last. I didn't carry that symptom on for years and years and years, and yet I had that symptom. In the same way that many dissociative experiences are completely normal, provided they don't go on and on and on and have that impact in life. And that's what we search for when we're trying to arrive at our diagnoses. Another question that has been asked by the subscriber is, can I recover? Can I actually get better? And what form does that take? The answer is, as with all dissociative experiences like this, is that it's about establishing control. We can't remove the ability to depersonalize or derealize from an individual because it's a thing that's built into the neurology of the brain. What we do is we help a person establish control over it. So if a person is more likely to have these experiences when they're experiencing heightened levels of stress, the simplest thing to do is, instead of waiting till you get to the top of the stress ladder or hierarchy, if you like, we work out a way of being able to help the person recognize those symptoms earlier on. So if you see dissociation, and in the Polyvagal Theory, this is one of the things that we look at in terms of the building level of stress and the reducing tolerance we have to stressful environments, is that if you say you'll climb a set of steps, and the more steps you climb, the more stressed your body becomes, so that at the top you hit the threshold where you're likely to dissociate. Instead of waiting till you get to the top and then medicating yourself or using self-harm to avoid your emotional experiences, for example, then we work on getting a person to notice that their stress is increasing from an earlier stage. So on step 2 or 3, notice that something is going on and begin to start addressing the issues that you've got, rather than allowing it to continue until you basically, like, you punch through your threshold, and then you either have a hyper-arousal or hypo-arousal response, and then that's where the dissociation really kicks in. We'll talk about a lot more about this, what's called the window of tolerance, in another video. So to notice that your stress level is increasing, to start reducing that stress in proper ways, in ways that are actually useful to you. So using grounding techniques, being aware of the objects in the room, using systems of sound and touch and smell, these sensory type experiences which allow you to start reconnecting with your environment. So if you see your body as being a different size, to be able to use some gentle touch, to be able to touch objects in the room, to basically like acclimatize yourself back to the reality of the space that you're in a safe way, in a way that you've been guided to and you've been assisted with, likely through a therapeutic relationship with somebody. So they can help teach you and work with the strategies that would work best for you. And what works well for one person may not work for another. So for example, one person, in order to overcome depersonalization, might have a shower, and the act of the water hitting the skin and the smell of the shampoo and the soap actually brings that person back into their body. For another person, a shower could be incredibly triggering, so you have to know exactly what you're working with a person to be able to advise on those strategies. So developing grounding techniques isn't so much like just grabbing a book on grounding techniques and doing everything within it. It's a trial and error approach that you require support and assistance to go through. With derealization, you might be in a room and you might think, okay, there might be specific objects. So in my therapy room, there's a number of different objects located throughout the room that basically don't ever change. They don't move around, they're always there. If a person starts noticing that their focus has changed, or the room starts appearing smaller or bigger and they're starting to feel stressed, starting to feel frightened, maybe a fog is appearing, they can't quite hear me properly, I appear much further away than I actually am, and they're able to notice that, or I can observe that taking place and check it out, what I do is I get them to look around the room, to start naming objects in the room, to pick up objects that they're familiar with, so they hold, they connect, and they anchor themselves into that space in the room. And very quickly a person brings themselves back from that derealization episode. That gives them the confidence to go out and try it again, and then they build an environment around them of consistency. So people that are having therapy in different rooms every week with the therapist are going to struggle to build this in. So again, it's about trying to make that environment consistent so they've got that to anchor themselves onto. One of the problems about being able to access the therapist is finding somebody that is suitably experienced and suitably treated. So being able to contact your GP or your health providers and ask for assistance in gaining diagnosis in a dissociative disorder. You might be successful, you might not be. So it's about keep on trying to understand exactly what's going on in the health field around you, and search out for the people that might be able to direct you in the best possible way. Not always easy, and it's obviously very difficult if you feel as if you have a dissociative disorder that needs looking at, but you can't actually access help. All I would say is to continue trying. I'll probably do another video again about steps that you might be able to take to help health professionals be guided towards what can be done to help you with your dissociation if they don't already know. But like I said, it's not on many training courses, so the likelihood is that people aren't aware. Lastly, the subscriber wanted to know what good resources would be available, and I've got two which I think would be particularly useful. So the first is this, which is called A Logical Way of Being. So this is put together largely by First Person Plural, but also with the Pottergate Centre, with the NHS. And what it is, it's a DVD describing all the dissociative disorders, what they mean, where they come from, and a sense of what it is that people can start doing in order to be much more in control of their own dissociation. So that's available from the First Person Plural website. So classic plug, it's a really good DVD and I'm in it. So obviously I'm going to say nice things about it, but it generally is an exceptional tool, and it's being used in many different places, and it's also something that you'll be able to give to your healthcare providers to help them understand what dissociation is. And the other resource that I'd like to offer you is Trauma and the Body. And this is a sensorimotor approach to psychotherapies, and it's an understanding of how dissociation affects the body and the body's relationship with the environment. And I think this is an excellent resource. There's loads of self-help skills within this to build confidence and to build the ability of people to understand and manage their own dissociative experiences. And within depersonalization, which is very much body-orientated, sensorimotor approaches have been found to be absolutely exceptional. There is mention also of the Polyvagal Theory in here, and there are some really good examples. For example, there's an example in here of a soldier reported in 1972 describing a depersonalization out-of-body experience. So again, sort of going into the research and literature helps people understand that these are not new things. These are experiences that people have been having for many, many, many years, and to be able to share these resources with healthcare providers so that they can understand what's going on. For therapists, Pat Ogden and the Sensorimotor team, they provide loads and loads of different training courses, so I would very much encourage people to see whether there's any Sensorimotor training local to you and jump onto that, because it's always high quality and it's always useful in all aspects of therapy. So there we have it. DPDR, depersonalization, derealization, in a nutshell. I think that there definitely is room to expand on this in different videos, and perhaps what I'll do within the CTAD Clinic channel is develop a video for each and every one of the dissociative disorders, so that I can really sort of thrash out exactly what those are all about and show the differences and the similarities between them. In the meantime, thank you very much for watching. I hope I've been able to answer all the questions as best as possible. I'm sure I'll get some feedback if there's anything I've missed out, and I'm totally fine with that. And so please like and subscribe if you want more content from the CTAD channel, and I will see you all again soon. Thanks ever so much again, and take care.